Okay, anyway, I'll try and, basically what I want to do is supplement the lecture a little bit. So I didn't have time to really go through and add this stuff to it just because I didn't have time to re-record it. The rationale for moving the class seemed legit to me, so I wanted to get you guys recordings and the content. Honestly, not a lot has changed with depression management from the lecture I posted, so it's pretty much the same. I just wanted to, I did a CE this last fall that had some good resources as far as the guideline comparisons for treating depression. And I think that's one thing where it's a little bit confusing. And so I'm going to teach you mostly on what's on those slides, but I do just want to give you a couple of pieces of background information on these review slides I've got here. So this is a treatment table of the current depression guidelines. You can see some of them are kind of outdated. I mean, we're looking at almost like 10 years for some of these guidelines. And they are all over the place if you compare them. So for example, first line, pretty straightforward. Pretty much first line, well, we're going to start with an SSRI, right? So your citalopram, S-citalopram, sertraline, fluoxetine, paroxetine, missing one. But anyway, you're going to start with an SSRI or an SNRI potentially, but usually SSRI therapy is by far and away the first line. Most people agree on that. Well tolerated, easy to titrate, known response for most patients, and good efficacy overall. So those are going to be pretty consistent. Now, when you go to second line therapy, that's where things get a little bit muddy. So, for example, NICE is pretty straightforward. Alternative SSRI or SNRI, well, that's kind of what I talked about at the lecture, right? You kind of try a different one in the major class, or you switch to an SNRI. Usually, we never double up SSRIs, so two serotonin agents that are both the same mechanism. There's no benefit in synergy with combining those. You can sometimes, really rarely, sometimes I see people add SNRIs to an SSRI. It's a little controversial, so I'm not going to teach you guys to do that. So for the purpose of those classes, you're on one or the other, not both. But an alternative to an SSRI, a good option to try if somebody's just really not getting responses in SNRI class. So like duloxetine or Effexor, venlafaxine. Tricyclic antidepressant, I would never put somebody on one of these as a second line. That's not even correct. So you can see some of these guidelines, even though this is still an active guideline in play, just not something people really do in practice. So let's talk about 2010 APA. So a little bit more mainstream maybe, but still kind of outdated at this point. Alternate antidepressant. So they just say alternate antidepressant. Whatever that means is up to you. So you can see these guidelines get a little nebulous, right? There's not a lot of evidence of head-to-head things in psych. It's not like cardiology where we have these really defined, more prescriptive algorithms in the guidelines for how to treat. It's a little bit, try your own thing, see if it works. A lot of psych therapy is based on familial response. So there's a lot of genetic components to psych. So like if your sister has depression and fluoxetine worked really well for her, that's probably what the psychiatrist is going to start you on. The rest of it's going to be probably personal preference. Like, hey, I work with adolescents and I find that S-citalopram works really well with them versus fluoxetine. I'm just making stuff up, by the way, just as an example. But so I'm going to prescribe S-citalopram. Yeah, it comes down to some of that stuff because really there's not a lot of evidence that says one's better than the other in a lot of these cases. So these ones aren't too different. Where I want to point you out is the Canadian guidelines, which are a little bit newer. They actually say if you get partial response, you augment immediately with an antipsychotic like aripiprazole or Abilify, which we're going to talk about today, which is kind of an interesting choice. That's been done for years, and augmentation with an antipsychotic is a really popular second choice. Maybe not necessarily the immediate one, though. So I think the Canadian guidelines are being, I don't know, a little aggressive in pushing the antipsychotics. They have a lot more side effects than anything within the antidepressant class, really, if you compare them just as two groups generally. Abilify or aripiprazole here is relatively well tolerated. Quetiapine isn't. It's going to cause a lot of sedation, possible weight gain. Risperidone causes a lot of movement disorders, hyperprolactinemia, so it can cause like breast development in men and menstrual disorders in females. So there's a lot of issues with them that you just don't see on the whole when you compare even some of the other classes or drugs that are sort of by themselves. Like you compare bupropion or mirtazapine or even some of the newer ones like Olanzapine or Vibrate. Those ones are all slightly different than a standard SSRI, right? But they still generally don't have a terrible side effect profile. They're pretty well tolerated. Once you get into the antipsychotics, your side effects go up exponentially. And as we're going to talk about today, those drugs are really dirty. They hit a lot of different receptors. And that's why you see a lot more side effects when people take those medications compared to a standard SSRI or SNRI or a serotonin-focused agent. Third line, you get a little bit more muddy, and then you kind of just throw the kitchen sink at them. You can see it does fall into a lot of what the STAR-D trial developed in the first place, so augmentation with things like lithium and mirtazapine. if you get to a certain point, trying thyroid hormone, so active thyroid hormone, liothyronine, if you're going to do some labs and find out the person doesn't have enough of that specific hormone. Then there's some other options that they do here too. Psychotherapy is pretty much on all of these at some point, or it should be. Let's see, where else we go. Once we go to very far down, it's pretty consistent too. So you're looking at salvage therapies, which I'd consider either MAO inhibitors, so monoamine oxidase inhibitors that are going to be really rare. Don't spend a lot of time thinking about monoamine oxidase inhibitors. They're super rare. I would just like you to be able to recognize what they are on the test. So if they come up, probably not the right choice unless I'm asking you specifically about them. But I'm not going to give you a case where that's the right choice to put somebody on, because that's a super involved decision to make. It's I don't know. I'm trying to think of people I've actually seen on MAOIs in my career. It's a handful, like less than 5. And I work behavioral health, and I'm actually on behavioral health again. Every once in a while I staff up there. And it's super rare to see somebody on that regularly. So ECT is probably a lot more common for treatment resistance, believe it or not. We do a fair amount of ECT. If meds aren't working, if you tried a number of cocktails, the patient's non-adherent, if they're really high risk, ECT is probably something that they're going to recommend over like a more salvage therapy medication in a lot of these cases. So definitely popular. It's actually pretty safe. It's cool. If you ever work in, if you ever do a psych rotation, I don't know if it's required or not for you guys, but if you work at a facility that does it, I'd recommend just observing one day. It's kind of interesting. They basically do really short-term paralysis. You have an anesthesiologist there making sure you're breathing, but you aren't intubated or anything. They give you succinylcholine, which only lasts a few minutes. And during that few minutes of paralysis and sedation, they do a controlled seizure. And so the psychiatrists who specialize in ECT understand how much wavelength to put through, how much electricity to give, and for how long to do it. And then you usually do it for like a week or two in the first step. And you can repeat it depending on how it goes, but it's definitely interesting. It's very fast. The results are pretty good, actually. The evidence behind it is fairly solid, believe it or not. So people kind of think of it as maybe archaic or a little bit cruel even, and it's definitely not. That's your picture of ECT. I encourage you to watch a video of it online or something like that, because it is pretty interesting therapy. But not really pharmacy related. So what I did want to show you is this algorithm that I pulled out of the CE I did, which I think pretty neatly puts it all together. So it starts with initial treatment. With the patient, you're going to discuss pharmacotherapy and psychotherapy, and possibly CAM would be complementary alternative methods. That would be in a patient who's resistant to pharmacotherapy, right? If they wanted to try complementary and their depression's mild, you could consider it. If it's pretty severe, I'd probably recommend to move them in a different direction. There's not really any good evidence that complementary medicine helps with depression. There's some studies about vitamin D. By itself, it's not proven to do anything to depression. If you combine it with an SSRI in people who are vitamin D deficient, it is shown to be better than the SSRI alone. So there is some possible augmentation there with vitamin D alone, but people take all kinds of supplements for different reasons, and there's just not a lot of benefit in studies out there in depression. So if you're recommending that for a mild case, sure. If somebody's severely depressed and suicidal, I think of that as a risk to recommend complementary medicine because there's no evidence that it's going to prevent them from committing suicide, whereas we have evidence with psychotherapy plus pharmacotherapy. Okay. So anyway, they talk about first-line pharmacotherapy, we have SSRIs, SNRIs, bupropion, mirtazapine, vortioxetine, which is Brintellix, which is another new one. All those could be considered first-line. Vortioxetine is brand name. Insurances probably aren't going to pay for it right off the bat. And again, for most patients, you're going to stick with an SSRI unless you have a really good reason not to. It's not like people are going to come into the office and be allergic to something like that off the bat. So it's not like there's, I'm trying to think of contraindications to them. There really aren't a lot. They're worth a try in most patients if they've never been on them before. Then I would probably go down the road again. If somebody is really concerned about sexual side effects, you could consider Wellbutrin right off the bat because it doesn't really have any. Mirtazapine also doesn't really have any libido loss. So that's maybe an option for somebody who's read about SSRIs and I've heard this common side effect. I really don't even want to think about dealing with it. It's a reasonable concern, so certainly something to think about. And then mirtazapine, I think of it as having some benefits for sleep. So it's kind of sedating. So if you take it at bedtime, it might help with insomnia, and it works as an antidepressant too. So you get that benefit. It also can cause some weight gain. So if you have somebody who's been not eating very much because they've been depressed, and maybe they could stand to gain a few pounds just to get back to a healthy weight, that could be something to recommend as well. So there's some utility with those other ones, but by far, I'd recommend SSRI as the first one. Partial response, suboptimal response. The way this is outlined in this box here, so 50%, 20%. What that means is a PHQ-9 score, so that's usually what they're going on. So where's your score when you first did your intake? Where's the score after your 4 to 8 week trial, and what's the decrease there? It's a way to quantify mental health, which is kind of difficult to do, as you guys have probably learned in other classes, but it is some way we can look at it from a little bit of a guideline perspective and say, all right, if your PHQ-9 is improving, we can see if the meds are working that way. It's somewhat of a marker that way. And then it goes through different options you can add on, basically like the things we just talked about. So the more odd things come down at the end. So ECTs, DCAs, MAOIs. I always kind of think of those as the salvage therapies. All right, some other interesting stuff about depression. Phases and timelines. Let's just talk about this because I don't think I really went over this in the lecture before. The acute phase of depression is weeks 1 through 4 to 8. Really, I put 6, 8, 12 there just because I didn't really have another place to put them. But anyway, week 1 to 2, you start an antidepressant. You should have increased energy, improved sleep, and improved appetite. I talked about this being the risk factor and why people have why the black box warning is on antidepressants. People get energy, people might be motivated, people might still be kind of having a depressed mood. So if they're suicidal, they might be more prone to kill themselves in that time period because they have the energy and the motivation. It's more common in young adults and teenagers than in older adults. Weeks 3 to 4, this is where your mood improvement should start to kick in on the antidepressant. Increased interest in activities, decreased feelings of hopelessness or helplessness, increased self-care, better concentration and memory. So you should start seeing more of the neurologic and psychiatric effects of the antidepressant that time. Weeks 4 to 8 is like where you would target your dose. So if weeks 3 to 4 you're seeing good response, look at your dose. Can you go up a little bit? Should you go up a little bit? Are they having any side effects? What's the optimal target dose for this person's specific disorder? And then targeting it that way. Weeks 6, 8, and 12, you want to continue treatment, and at those intervals, you evaluate for optimization. Again, you need to add something on. Maybe the person's having sexual dysfunction on SSRI, so you add a little bit of Wellbutrin. Maybe they're tolerating the drug really well. Maybe they're younger, so you're suspecting they're a high metabolizer, and they could benefit from a little bit higher dose, so you continue to tweak that dose as you go up. Continuation. After a first major depressive episode, treatment should be continued 4 to 9 months after a response is achieved. So that's really the gold standard for how long you treat an initial episode. So I put that in there, and I think it's important to talk about this with patients who have an initial depressive episode, that people don't always stay on these drugs forever. Some people do, but a lot of people can get off of them if they choose to do so and if they feel comfortable, and if you as the provider feel comfortable with that. Risk of relapse, 20 to 85% without continuation phase of treatment after initial response. So that means if somebody gets to like week 4 or even week 12 or whatever it is, but they don't continue for the full 9 months, this is their risk of relapse. It's a big range, right? Studies are kind of all over the place. But the point is if you get through that whole treatment phase up to the 4, 5, 6, at least 9 months, something in there, that's when you see the benefit, and the risk of relapse goes down substantially. If you discontinue it before that 4-month mark, or the patient decides to stop it before the 4-month mark, that's where we see relapse rates go higher. Time to recovery, usually 5 months with adequate treatment, and this includes psychotherapy too, so not just drugs. 50% of patients who have a single episode of depression will recover without recurrence. So again, I think that goes a long way to talk to people about this, to say that not everyone has to be on an antidepressant for life. Not everyone is, if you have an episode of depression, it doesn't mean you're going to be depressed for the rest of your life either. So some people that our behavioral health team at Abbott does some classes, and that's a really common question I get from patients, like, how long do I have to take these medications for? And it varies per person, right? But there are some guidelines and time frames out there that are pretty well studied as far as what targets we shoot for, especially for that initial response. Now with recurrence, risk of depression increases with number of depressive episodes. So after a recurrent episode of MDD, treatment should be considered for at least 1 year. And then after that, if you have 3 or more recurrent episodes, you should probably consider lifelong therapy at that point. So certainly, just like with a lot of diseases, we want to manage them aggressively if we need to. In those cases, it's probably worth doing a lifelong therapy for those patients. All right, a quick case. Okay, JJ is an 18-year-old female college student who's been given a diagnosis of a first episode of major depressive disorder. She presents to student health clinic for initial treatment of depression. Her symptoms include unintentional 10-pound weight loss, significant psychomotor retardation, constant feeling of hopelessness. Current BMI is 28 kilos per meter squared. All their laboratory values are within normal limits. Question 1. Which of the following is best to recommend as JJ's first-line treatment for MDD? Heard A. Anyone else have an opinion? What are A? What is A? It's an SR. What's mirtazapine? It's its own thing. Trick question. So mirtazapine is basically a serotonergic agent with some other effects too, but I think of it as targeting serotonin receptors directly versus causing reuptake inhibition. So similar system, different overall method of stimulating. Nortriptyline, what's that? Tricyclic. Yep, so it's a tricyclic. So do we ever start patients on tricyclics? No. Paroxetine. SSRI, so it's Paxil. Why not Paxil? They're both, so A and D are both SSRIs. A lot of people said A. Seems to be the common choice. Why?
Paxil bad.
Yeah, Paxil is technically a first-line agent. I actually pulled this out of the CE, but it asks questions a lot like I like to ask questions, so I liked it. Paroxetine, so the reason the CE said not to do it is because she's of childbearing age, potentially. Personally, I think the reason not to do it is anticholinergic meds suck, okay? Don't prescribe them if you don't have to. I don't understand why people decide to prescribe Paxil right after that. It's just there's better choices out there that are less anticholinergic. People are going to be uncomfortable with the side effects. And even if it's mild discomfort, better to try something else. So yeah, fluoxetine's a great choice, first line agent. No problem there. So A would be the correct answer. 2. Which of the following is the most important counseling point to give JJ about whatever you're going to discuss with her based on these here? So you've got A, abrupt antidepressant cessation may cause serotonin discontinuation syndrome. B, after initial response, the period for continuation of treatment is 4 to 9 months. C, adding routine exercise and lifestyle modifications help to treat depressive symptoms. D, is where I'd probably put all the above. But D, the risk of suicide is increased, especially during the first 8 weeks of treatment. I want to ask you a question like this. This is getting a little bit tricky because these are all correct, right? They're all good counseling points. What do you think the most critical one out of these is for her? I think D is what the CE put, and I would tend to agree that it's probably the most crucial, especially since she's 18. So that age is important when it comes down to that. But then again, these are all good. I wouldn't ask you a question like that. I think that's a little tricky, but it's a good question to think about. Like, okay, I'm going to prioritize my counseling tips. The person might not remember everything you say. What's the most important thing for you to tell them about a new med you're prescribing? Okay, 3. After 8 weeks of antidepressant treatment, JJ presents with less than a 20% symptom improvement. Which one of the following is the next best step for JJ's depressant treatment? So this is when, if you're doing a CE, you can go back and look at this. So I wouldn't ask you percentages, but let's just say she had 20% suboptimal response and symptom improvement. Basically, not a whole lot happened. So based on this, you would go to an alternative antidepressant in the same or different class, plus or minus psychotherapy. So with that in mind, which one of these might be okay? Yeah. So Effexor is a really great second choice for somebody who's really not responding to an SSRI. This gets confusing because if you look at the Canadian guidelines, they'd say add Abilify, right? Which is aripiprazole. Again, I wouldn't recommend doing that. I'd try a different agent first before trying that. What's phenelzine? What's the kind of drug class no one really uses?
MAOI.
It's an MAOI, yeah. So that's one to recognize, be able to recognize it on an exam, know what it is. Other than that, I don't really care much about them. All right, does anybody have any questions about depression or bipolar? We're going to talk more about the antipsychotic class, which applies to bipolar as well, so it might help fill in some of the gaps. They all kind of work together between schizoform disorders to the different bipolar disorders to depressive disorders. There's a lot of crossover in the meds we use to treat people. So anybody have any questions so far about anything we talked about today or any of the lectures previously? Okay. All right, schizophrenia, DSM-5 criteria, 2 or more of the following symptoms: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms, which I think of negative symptoms as something that should be there but isn't, and a positive symptom is something that shouldn't be there but is. That makes sense. So positive symptoms, hallucinations, delusions, you shouldn't have those. Negative symptoms, you should have emotion when you talk, flat affect. Have you guys ever heard somebody with flat affect? You know what that means? Once you hear it, especially with the schizophrenic patient, you'll never forget how it sounds. Social occupational dysfunction. This little drawing here is a Wayne Katz paintings, and the theory is that this guy named, I don't know, Wayne, this is his last name. I think that was his last name. But anyway, he painted cats, and the idea was that he was schizophrenic, and he thought that his paintings were like a descent into his schizophrenia, so he started painting a cat that just kind of looks paranoid and a little off, and then to this thing that looks almost like some sort of demonic creature. But some people debunked it and said this is just the way his mother's wallpaper looked in his house, and that's what he was painting. So anyways, it's kind of a funny little cultural fact there. I don't know, those cats look kind of weird and scary to me, though. All right, here's my schizophrenia joke for the day. It's not paranoia if the cappuccino is really out to get you. All right. Okay. Schizophrenia epidemiology, about 1% of the population. Relatively rare. It's not super common, but very debilitating to people who have it. Similar among all different cultures globally. Similar rates between men and women. Slightly more common in men. The age onset is different. For men, usually it's a little earlier. Age onset's generally for men in the late teens, early 20s. For women, it's usually early 20s to later 20s. But young adults, it's common to see that start. So like the typical or the textbook presentation is the kid who goes to college, is social, outgoing, and then withdraws into his room and starts coming up with crazy conspiracy theories and doesn't take showers, and then people start to notice and whatever. So that's kind of what I think about when I think about the onset of schizophrenia. But certainly it can happen other ways as well. It can happen later in life. It can be drug induced too. So talk about drugs of abuse this summer. But like methamphetamine use is associated with psychotic disorders as well. Okay, so suicide rate is about 10%. That's going to be the major mortality factor when it comes to schizophrenic patients. So treating them is important to prevent that. That's really our goal here. 20 to 40% will attempt suicide. 20% reduction in life expectancy over a normal person who does not have schizophrenia. High rates of substance abuse, although this is a little questionable. It was thought for a long time that approximately 75% of schizophrenic patients smoke cigarettes, but actually they've done follow-up studies and they're all over the place with what percentage. But it does seem to be there's a high-ish compared to the normal population of co-substance abuse, whether it's smoking cigarettes, vaping nicotine, or using marijuana or cannabis. Stages of schizophrenia: prodromal, gradual symptom development, may go unnoticed, kind of like what I just talked about. Acute phase, full-out psychotic behavior accompanied by a lack of ability to care for somebody. Stabilization, acute symptoms will generally decrease over several months. And then stable symptoms mostly are completely gone. Depression or anxiety may be kind of a residual leftover thing. Complete remission from schizophrenia once it starts is very rare. It's quite difficult. Even with really good medication management, it's not always possible to treat all the signs, all the symptoms related to schizophrenia. Generally speaking, our drugs are really good at the positive side, so we can stop hallucinations and paranoia and delusions. What we can't do all the time is improve those negative symptoms. So bringing back full affect, improving cognition, that's the tricky part. And I'll talk about some of the drugs here and what they do in a second. All right, two major groups of antipsychotic. They've been called atypical and typical for a while. However, atypical antipsychotics are the newer ones. So they're the second generation, or SGAs is how you'll hear them abbreviated. Typical antipsychotics were the first generation, the older ones. So first and second generation is the more common way we talk about them now. That's how I'll refer to them. But I might slip up here or there. Development of these agents dramatically changed mental health treatment. Before antipsychotics, there was not a whole lot you could do for schizophrenia. You could do ECT. That's been around for a while. That was pretty much it. There wasn't a lot of other behavioral modification pharmacologically that you could try. And psychotherapy doesn't really work for schizophrenia for hopefully obvious reasons. There's a lot going on that you can't just work out as far as like talking and going through cognitive behavioral therapy. Sometimes that might help certain things, but it's not going to help somebody's paranoia mostly. That's going to be something it's hardwired in the brain differently. Usually drugs are the only way to assist with that, or ECT. People used to try insulin coma induction. which isn't done anymore for obvious reasons, but they basically drop your blood sugar to the point where you'd have a seizure. It's kind of like the ECT concept. It was an induced seizure, but ECT is a much safer way to induce a seizure. Lobotomies, too. Obviously, we don't do that anymore. Don't memorize this chart, but you can refer back to it if you're curious. This is just the reason I put this in here at all is to show you guys all the different receptors that antipsychotics target. So these are all the second generation antipsychotics, most of them. There's a couple of new ones not on here. But you can see they have affinity for receptors all over the spectrum. So they hit a lot of dopamine receptors, serotonin receptors, histamine, muscarinic, alpha. They inhibit some norepinephrine, serotonin reuptake in some cases too. Compare that to like a first generation drug like haloperidol or Haldol, mostly just a dopamine agent versus not really doing a whole lot to the serotonin side. So that's one of the biggest differences between the two classes of first and second. First generation antipsychotics, think about them as mostly dopaminergic activity with very little, and they're going to be blocking dopamine, so they're dopamine antagonists. And where we have the newer drugs that actually have more of a focus on serotonin, but they still do the dopamine thing too. So they kind of took part of the first generation idea, skimped it down, and then added on some other things too. So I'll talk about why that's important in a little bit, but just as a background. As far as mechanism of action goes, why we target dopamine and serotonin, dopamine psychopharmacology has to do with different areas of the brain. So you have the mesocortical and mesolimbic pathways. The mesocortical pathway, dopamine hypoactivity is going to cause your negative symptoms, so you don't have enough dopamine activity in that area of the brain. Mesolimbic pathway, dopamine hyperactivity, is going to cause positive symptoms. So you can see there the dilemma right away with drugs. So we can block dopamine hyperactivity in the mesolimbic area pretty easily, but doing that and increasing the dopamine to the mesocortical pathway is not easy to do. That's why sometimes you end up with this piece getting taken care of, these positive symptoms. Your negative symptoms just stay kind of flat, or they might improve over time. There's some theory that maybe your dopamine kind of shunts itself there eventually if you're blocking certain sets of receptors. It's possible, but that might take time for the drugs and all the remodeling to go on in the brain for that to happen. A couple other things that dopamine affects: the nigrostriatal pathway is motor control. So death of neurons can result in Parkinson's disease. So that's why when you give people a dopamine antagonist, you cause Parkinson's-like symptoms. You cause movement disorders and tremors because you're blocking dopamine activity in an otherwise healthy non-Parkinson's patient in that specific area of the brain. This pathway, tuberoinfundibular, that's an interesting word, hormone regulation, maternal behavior, pregnancy, sensory processes. That has to do with some of the drugs that cause increases and changes in prolactin. That's pretty much the main side effect there. Okay, so what about serotonin? Why is serotonin preferred? So we talked about dopamine, how it can help by antagonizing those receptors in those specific areas of the brain. You get a decrease in positive symptoms. Serotonin is thought to improve cognition. So if you have overactive serotonin in certain areas and you inhibit it and shunt it to other parts of the brain, the idea is you can help improve those flat symptoms. So that's where it comes down to the first generation antipsychotics really do target dopamine specifically. They don't have a lot of effects on the serotonin pathways. It's thought that that's why the second generations have more of an advantage when it comes to improving those negative symptoms, improving the flat affect, improving cognition. It has to do with this type of a system that you're working with. All right, side effects. So what happens when you give these drugs? Lots of things. Like I said, these are dirty drugs and they cause a lot of side effects. Dopamine, when you're antagonizing the dopamine receptor, so you're blocking it in certain areas. Again, we just talked about the Parkinson-like effects. So we call these extrapyramidal side effects, or EPS. So you hear drugs cause EPS, or that drug has a lot of EPS, or he's getting EPS from risperidone or whatever it might be. That's what we're talking about here. Prolactin elevation also has to do with dopamine receptor. Serotonin can cause messing with serotonin receptors can cause nausea, sexual dysfunction, orthostatic hypotension, and weight gain. Excuse me. Adrenergic can cause orthostatic hypotension. Histamine receptor effects can cause weight gain and sedation. Acetylcholine hitting that muscarinic receptor, so you get all the cholinergic type effects off of that, or the anticholinergic, excuse me, because you're blocking the receptor. So you can see, depending on the drug's profile, Like some drugs don't have a lot of histamine. So Lorazepam, for example, isn't really associated with weight gain. That's thought to be, when you centrally antagonize histamine 1, for some reason that's thought to be associated with appetite stimulation and weight gain. This drug doesn't really have it. Ziprasidone also doesn't have a huge amount of it. But drugs like, Olanzapine and Clozapine, more active there, which are going to cause more weight gain. Same thing with anticholinergic effects. Clozapine and Olanzapine both have quite a bit of stimulation. Really, the rest of them don't. So that's where we see a lot more dry mouth with people on Clozaril or Clozapine. So you can see that's why the receptors matter as far as side effect profile. Where you want to target is dopamine and serotonin with little activity elsewhere, and that's where it can be hard to do because the molecules are kind of similar, so they're going to hit multiple different receptors. Okay. This is a handy chart, and I don't think it has every drug on here. There's a couple newer ones that they aren't really getting used a whole lot yet, but it's got most of the new ones on here. But this will show you the side effects. Of course, more pluses, more side effects. So if you're prescribing medications or working in psych or doing a psych rotation and you want to know, this is from UpToDate. Go on there. They've got this chart's really easy to find under their antipsychotic summary, and you can look at all the information for different side effects. So if your patient's having a lot of EPS, for example, on paliperidone, which is a newer medication, you could try and switch them to something that maybe doesn't have any EPS or less EPS. So that's a nice way to strategize how you're going to approach changing therapy or modifying medications. If you look across the board too, like aripiprazole or Abilify, one of the reasons it's so popular as an adjunct therapy in bipolar and depression is because its side effect profile is pretty clean across the board. For being a dirty drug, it causes a little bit of EPS, mostly dose-related. It can be a little bit sedating, but that's pretty much it. Lorazepam is another newer one that's pretty clean. A little bit sedating, a little bit of EPS that's dose-related, not a whole lot else going on with it. So newer drugs, ideally, are going to have better profiles than some of the older ones. Clozapine, see it looks nasty all across the board. This is reserved for salvage therapy, and it's one of the older drugs available, but it's also a really effective one. So there's the trade-offs you have with different side effect profiles as a possibly more effective medication. So extrapyramidal symptoms versus something called tardive dyskinesia. These are two things to be aware of and to know about because they're probably the two biggest side effects that people think of when they think of, well, maybe one of two. Movement disorders and weight gain, I think what people come into mind when they think of an antipsychotic. So EPS, again, akathisia, Parkinson-like symptoms, dystonias, associated with acute antipsychotic use, treatable. You can treat EPS, you can mitigate EPS, you can stop the drug and EPS will stop. It's fully reversible, it doesn't last, and you'll see it fairly quickly when you give somebody a drug. Usually once it hits its Cmax, so maybe within a couple hours of ingestion, that's probably where you're going to see it. Tardive dyskinesia is kind of the opposite of EPS as far as the onset and the treatability. It's a permanent related effect. It's usually more, it's not really full-on tremors or movement disorders like you might think of Parkinson's-like side effects, but it's more about involuntary facial movements like sucking, moving the tongue, making weird lip movements. If you ever interview a patient with TD, you'll know it. It's pretty obvious what's going on, especially if you're working in psych. And again, this is often irreversible. It can come on really at any point within treatment. Usually it's after 6 months, though, so you don't see it in the acute phase, which is unfortunate because it can be frustrating for patients, obviously, if they do develop it, which is why we like our second generations a little bit more. They have a much lower incidence of tardive dyskinesia. First generation antipsychotics, much, much higher incidence of both of these. Our second generations obviously can cause a little EPS. As I said, most of that's dose-related. Tardive dyskinesia is quite rare for a second-generation antipsychotic. Yes?
Can you minimize EPS with like Benadryl?
Yep. I think I've got a slide on that, but yeah, anticholinergic medications actually minimize EPS. So like if we give haloperidol, for example, it's a first generation, a lot of times they give that in conjunction with diphenhydramine, or there's a medication called Cogentin or benztropine, which is an anticholinergic medication that's not quite as sedating as Benadryl. And that's much more common in psychiatric medicine. So you'll see those two given in conjunction very frequently. All right, let's talk about first generations quick. First generation antipsychotics, again, mostly have fallen out of favor. However, if you work in more advanced psych areas, so like if you work inpatient psych where you're seeing some of the worst cases where people have tried lots of different therapies, The odds are you might see some of this used occasionally. We do bring them back for people if they've tried a lot of the newer agents and they just aren't working. The thing is, they're effective. And in fact, there's a lot of studies out there that show that basically first generations are just as effective for the most part as second generations, maybe with some trade-offs here and there, but they do work quite well. So if you haven't had success with the second generation options, a lot of times they'll go back to the first gen options and see if they can find something that is more effective for that patient. We never use them first line, but they are pretty effective. So again, it's more of an unresponsive thing for the second generation agents. Just to go over a couple examples, haloperidol is one you should definitely know, or Haldol is the brand name. It's a really old drug, but it's used very commonly today. It's not necessarily a common maintenance medication, meaning people don't take it chronically, but people do use it acutely. So if you work in an ER and you have somebody who's agitated, haloperidol is a common med. You can give them intramuscular, so you can get it into the body fairly quickly that way. And there's also a long-acting injectable. So for some patients who are using haloperidol regularly and they don't want to take oral medications, you have to take oral Haldol 2 to 3 times a day. An ion long-acting shot that you can get like once a month is a lot more convenient for these patients, especially with this patient population, right? Adherence is tricky for a lot of them, depending on how severe their symptoms are. So if you can get somebody out with a month's worth of drug without having to worry about whether they're taking it or not, it's a huge benefit. So there's a lot of ion long-acting agents, and I'll talk about those as we go through them. I think of haloperidol kind of as like the typical silver bullet. So it's the old drug. It works pretty much on dopamine. It has, some serotonin activity, but I think of it basically as a pure shot to the dopamine receptors. It's kind of sedating too, so people will usually be knocked out pretty cold while they're on it, if you give them, especially if you give them an IM shot of a fairly large dose. And again, those are the cases where you would definitely want to combine it with Benadryl because you want that you want to prevent that EPS from occurring. I don't know if this is really well studied or documented, but a lot of the ED providers I work with are pretty consistent where they say that if you wait until somebody gets EPS and then you give them an anticholinergic med like Benadryl, it doesn't really work to stop it. But if you give it with the drug or right before you give the drug, it's a lot more effective and you see it a lot less. So definitely combine them. And again, a lot of times the orders are combined. So people will take their benztropine or diphenhydramine at the same time they take their haloperidol. First generation, other ones, there's a couple other ones that I see used occasionally. Perfenazine. Perfenazine is kind of think of as an intermediate potency agent. It was studied extensively in a trial called the CATIE trial. And the CATIE trial was a trial that came out when the second generation antipsychotics were relatively new. There was a few of them on the market, 3 or 4, that were all studied against perfenazine. And the reason was they were really expensive, and people were just wondering, are these actually better than our old drugs that are cheap? And so they studied perfenazine. They didn't show that it was any different in outcome than the newer second generation antipsychotics. Now, this is a while ago, so we have some newer drugs even that haven't really been studied head-to-head against perfenazine. But overall, it sort of enforced the mentality that first generations are just as effective. Just again, you have those trade-offs of the side effects. Thiothixine or Narvine, sometimes we see this used. Chlorpromazine or Thorazine is another one that's used for, and again, I don't really want you to know many of these. I'd say no haloperidol, no perfenazine. That's it for first gens. The other ones, if you do work in urgent care or ER, you might get familiar with chlorpromazine. If people come in with retractable hiccups, that's the first line choice for it. It's a really bizarre thing. It has some sort of GI-related reflex that it causes. I won't test you on that little factoid, just for your information. All right, treating or preventing EPS. Talked about this extensively already. I don't think there's much more to say. Basically, again, diphenhydramine, benztropine, PRN or scheduled. Again, I would recommend scheduling it, especially scheduled benztropine with scheduled haloperidol is really common. Most patients on second generations don't need these, but every once in a while, I feel like Abilify for some reason tends to get, maybe just because it's so common, or aripiprazole as a second generation seems to be associated maybe more with EPS than other ones I've seen. That's just anecdotal. If you look at like incidence reports on a drug monograph, it really doesn't show up as like a blip. It seems pretty standard. But I feel like I see it a lot, or I'll see people coming into the ED, just started on it or dose increased on it, and they've got EPS on it. So sometimes I'll see benztropine with that, but for the most part, it's going to be with your first gen antipsychotics. And definitely don't feel bad about scheduling it. If you're going to have somebody on haloperidol, benztropine scheduled is probably a good idea with it. Okay, second gen. Second gen Risperidone. I'm going to go through these, not in any real particular order, kind of as how they are used, I think, in practice. But there's a lot of variability here, and they all have different advantages. And you'll see them combined, too. So you see people on multiple antipsychotics, which gets a little confusing as well. So you've got Risperidone, paliperidone. Risperdal is the brand name of risperidone, and paliperidone or Invega is the brand name of paliperidone. They're very similar. Invega is just an active metabolite of Risperdal. You likely have minimal efficacy differences between the two, but there is one really nice difference, which is at the very bottom with respect to their long-acting medications. Risperidone, really popular initial antipsychotic. The reason is if you look at all of our antipsychotics, the newer drugs look maybe shiny and nice, but they're kind of expensive, and insurances might not always pay for them. So if you look at our older drugs, which we're going to talk through here in a second, Risperidone has an okay side effect profile. It's a nice starting choice if you really have nowhere to go and you want to start somebody on an antipsychotic. But Risperidone is not a bad option to think about because it's pretty balanced. It's got some minimal dose-related EPS. It does have the highest incidence of hyperprolactinemia out of all medications, so that's probably its biggest downfall. Both of these drugs come in long-acting forms. Long-acting IM forms are not generic, and they're usually quite expensive. There's a lot of drug company-related assistance programs that will put people on them. The question is what's more expensive, having your patient in and out of the psych unit 4 times a month, or keeping them out with a $2,000 a month injection? Probably keeping them out with a $2,000 a month injection. So that's where you come down to it. Risperdal, Consta is risperidone. It's dosed every 2 weeks and requires a 3-week bridging period from the oral medication. I'm not going to test you on that. I'm just using this to highlight the differences. Invega Sustenna is the long-acting haloperidone, dosed once monthly, requires no bridging. So if you start somebody on oral Invega, it's working well, get them on a long-acting, you can do it pretty much right away. So this has become super popular among long-acting anti-injectables. In fact, it's probably the most popular one we have. The only time people will go to Risperdal Consta is if insurance just won't pay for Invega and they want to try Risperdal first. Depends on what kind of clinic access the patient has. If they're going to a group home and they're going to have regular interval checkups, probably not a big deal to do Risperdal. But actually the products aren't that big of a difference. You end up spending like $900 every 2 weeks on Risperdal Consta, and with Invega you spend like $2,100 a month. So it's like a couple $100 difference when all's said and done. I don't know. It's a little bit of a wash to me. But again, insurance companies will pick and pull out some of that stuff. Olanzapine or Zyprexa is often considered like the gold standard when it comes to second generation antipsychotics as far as efficacy goes. Doesn't mean it's the best option to treat people with, but it's really popular choice, super effective. It's been compared head to head to a lot of other drugs in its class, and it usually comes out slightly ahead. In fact, kind of the standard with psychiatric studies are kind of weird, especially with schizophrenia. So a lot of the drugs just have to prove that they work better than placebo, which makes absolutely no sense, but that's a lot of the times how they get approved FDA-wise. So they have to prove they work better than placebo, and the trials are like 8 to 12 weeks. Like, oh, that's really not helpful, thanks. But it gives us another option, I guess. I shouldn't rat on it too much. But you have Olanzapine, which some drug companies will get bold enough to challenge it and say, let's do a head-to-head Ziprasidone versus Olanzapine. If they can prove that it's not inferior to Olanzapine, that's pretty good. If they can prove that Olanzapine is just slightly superior to it, that's still pretty good. So Olanzapine is a very effective medication. Many newer drugs are really unable to prove that superiority to it, so it's quite, again, it's kind of set that bar for how effective do we want our medications to be. You can give it PO. It comes as an orally dissolving tablet, which again, most of these drugs do. Risperdal comes that way. The nice thing about that, right, is you get patients who cheek a lot in mental health. If they're, for some reason, avoiding medications. Occasionally, you need to get a court order for them to take their drugs. It happens sometimes. ODTs can help with that because it's a lot harder to cheek an ODT. Or if you do try and cheek it, it's going to dissolve, right? So they don't. One myth I'll dispel is that ODTs absorb sublingually or buccally. They don't. You actually swallow them, and that's how you absorb them. So they really don't have a much faster onset than a standard tablet. So I think a lot of people are like, oh, we need the ODT because it'll get on faster. It doesn't. It still has to go through the GI tract. I mean, maybe your gut doesn't have to break down the tablet, so it's slightly faster, but not a huge amount. IM forms of Zyprexa are really popular for psychiatric emergencies. So people who are really agitated haloperidol combined with Benadryl and combined with the benzodiazepine lorazepam have been a really common treatment for a long time. Zyprexa has pretty much replaced that. It's a lot safer. You don't get EPS with it. Zyprexa virtually has no EPS associated with it. So for acute things, it's great. It also comes with an IM long-acting every 2 to 4 weeks, depending on the dose and the patient product. It has what's called a REMS program. You guys are talking about REMS programs, Risk Evaluation Management Strategy. It's a pharmacy term, but it's important just to know what it is. There's a few drugs on the market that are like it. And basically, if you prescribe REMS drugs or you dispense REMS drugs, there's restrictions in place. So you have to go through training, you have to do extra documentation, you have to submit the person to a database sometimes. There's a lot of stuff like that out there. Doesn't mean you can't do it. Just so you know, Olanzapine is a REMS drug just because they think that it's associated with respiratory depression in some patients. So there's extra precautions around how you can give it and when you can start it. Mechanistically shifting, this is shifting quite a bit away from dopamine, which is why it doesn't have that EPS effect. However, Olanzapine probably causes the most weight gain out of any antipsychotic we'll talk about. So that's its big issue and why we don't start people on Olanzapine because of that weight gain. People gain like 100 pounds in some cases. It can be really substantial. And it's all about appetite, increased appetite. So if people are aware of that or caregivers are aware, they can understand portioning and things like that. But that can be really tricky. All right, Seroquel or Quetiapine. It's got a weak affinity for a lot of different receptors. So you'll see Seroquel given at really high doses. Like comparatively speaking, like risperidone, you give it like 1 to 6 milligrams is kind of the common dosing. For Quetiapine, you can see like 300 to 1,200 milligrams. So it's a weaker affinity product, but you just give a higher dose and you get the same basic effect. Some people do think it's a little bit less effective than some of the other options in the market. I don't know. It's useful here and there. One thing you'll see Quetiapine used for is acute low doses for agitation. So somebody might be on, let's use risperidone as our example. They're on risperidone daily. They might have an as-needed Seroquel at bedtime to help them sleep. They might have an as-needed one if they get anxious. And it's really low doses, like 50, 100 milligrams. Whereas like if you were taking it daily for schizophrenia, you're probably going to take like 600 to 900, maybe even up to 1,200 milligrams of Seroquel a day. So the doses, they vary a ton. So if you see a little old lady who's maybe got dementia on and has some maybe agitation related to it, you might see around like 25 milligrams of Seroquel every 4 hours as needed. Really small doses. It's actually pretty effective for that. Very low dose of EPS. It's generic, but there's some XR formulations that are a little bit more expensive that extend the release of it. The XR formulation is not a huge difference. It's like a couple hours you get out of it. So I don't know if I buy into it, but this is actually a really popular sleep aid too. So whether I like that or not, I haven't really decided for sure if I'm okay with that. But it's common to use low-dose Seroquel as a sleep aid. I just think using antipsychotics for anything other than mental health conditions is not a great idea when you have other options. But again, low doses of Seroquel, probably not a whole lot of side effects associated with them. So you will see that done as a pretty common sleep aid. All right, Ziprasidone or Geodon has a pretty good side effect profile. It was one of the first drugs to come out that didn't have really any weight gain associated with it. We talked about Olanzapine's weight gain. Clozapine and risperidone have like a little bit. They don't have as much. Quetiapine and risperidone, the other two drugs we talked about, a little bit here or there. People will obviously be different. I've had people tell me they gain tons of weight on Seroquel, but Ziprasidone was the first one to come out that really said that, nope, we don't cause any weight gain at all, so how about that? And also, we're activating, so our drugs doesn't sedate people and keep them basically asleep all day, which you might want some sedation in a schizophrenic patient. That's not a bad thing in all people. So that's something to consider with Ziprasidone, whether you want a slightly activating medication. Some people, it makes tons of sense. Other people don't. Yeah, you wouldn't even touch it. Generic, its QTC prolongation is probably the biggest side effect associated with it. It gets this, got this big amount of attention when it first came out that it was prolonged QTC, and no one liked it because of that. But actually, statistically, Quetiapine and haloperidone are not any better. So we have some new agents, we have some old agents. Those three are the QTC prolongers, though, for the most part. It's available IM for acute psychosis, but it is more expensive than IM Olanzapine, so we don't ever use it for that. We use IM Olanzapine for acute psychosis, second generation agent, at Abbott. Serotonin, norepinephrine reuptake. So it actually may treat some depressive symptoms more, well, I don't know if I'd say, yeah. I mean, if you have a depressive component to the schizophrenia, it could be a nice option to use for those patients. So, not a super popular one, but again, all these get some use, so they're all kind of worth talking about. Aripiprazole, or Abilify, when it was its brand name product, was probably the most, it was like in the top 5 drug sales for years. It's a really popular drug, and a lot of it because of its crossover. So people just love prescribing Abilify for everything under the sun related to mental health. And not to say that's bad per se, but I think it gets spread out a little bit more than it maybe should. But anyway, really good side effect profile, has some serotonin reuptake, so it has some antidepressant properties. I would say that this used as an antipsychotic is probably plays second fiddle to its adjunct use. So it's adjunct use in depression, anxiety, bipolar. Those are going to be the more common areas you're going to see Abilify prescribed. But certainly it is an antipsychotic. It's actually a decently effective one too, so you could use it for that. But it just seems to get more play in those other areas. I would say compared to like Olanzapine though, or Risperidone even, maybe slightly a step lower in efficacy, but still effective. I just put a little bullet here about Brexpiprazole, which is Rexulti. Rexulti is a brand new medication. As you can imagine, it's made by the same company. It sounds really similar. In fact, it's kind of like a Me Too drug, a little bit supposedly more potent. I don't know of any specific advantages with it, but people do use it. So yeah, there you go. I think, again, when it comes to schizophrenia, schizoaffective disorder, you have these different opinions on how to treat patients, and you try out multiple different things, and eventually you're like, this drug's new, haven't tried it yet, this person doesn't work for, nothing else works for this guy, so let's give it a shot and see what happens. Okay, I'm going to talk about Clozapine in the form of a patient case quick, and then we can take a break after we're done with Clozapine. So Clozapine is a second generation antipsychotic, technically, even though it's been around forever. It was originally, I think, approved in like the late 50s, and it got taken off the market right away because people were seeing dangerously low neutrophil counts with it. So it can cause agranulocytosis in really rare cases, and neutropenia, leukopenia in more common cases. So there's a lot of monitoring around. This is another REMS program drug. If you prescribe Clozapine, you have to be enrolled as in the database as a prescriber. You have to also have regular lab monitoring and things like that set up. And as a pharmacy dispensing it, you have to have all that stuff as well. All right, sorry, I have animations in here. Clozapine, okay, so this is a patient. I actually saw this patient when I was doing a rotation at the Saint Cloud VA. She was a 56-year-old white female. She presented to the VA Medical Center with acute exacerbation of paranoid schizophrenia. She had intense fear of what she called Mr. Menard, which apparently was John Menard. I don't think he's alive anymore, but it wasn't actually him. He wasn't actually doing anything to her. She didn't know him, but she thought he was out to get her. So, some of these things people come up with. Sometimes, it's just so bizarre. You got to smile a little bit at it, like what the human brain's capable of coming up with. She would arm herself with protection. She is compulsively checking locks. All right, her past medical history is significant for depression, sleep, apnea, anemia, obesity, hypothyroidism. She had medication non-compliance history, and she was diagnosed with treatment-resistant schizophrenia. So these are the different drugs she's tried. We didn't talk about fluphenazine. That's another first generation. But fluphenazine, thiofixine, Olanzapine, or Zyprexa. She got Risperidone Consta at one point for adherence reasons. Didn't help, unfortunately, or it didn't help enough. And then she was on Abilify. These are all, I don't expect you guys to know the doses. They're all really high doses, whopper doses. So she was optimized, if you want to put it that way. They gave it a good college try with the dosing. All right. She was hospitalized for 1 month. She started Clozapine during her stay. Clozapine is again brand name Clozaril. Her paranoid voices decreased. She had appropriate affect and sleep habits, and she denied any feelings of people plotting against her or self-harm. So basically a complete 180 on this drug where nothing else really worked successfully for her. So why Clozapine? Oops. It's effective in about 25 to 50% of patients who don't respond to typical agents. Similar results have been found with resistance to atypical treatment too. So either whether you're resistant to your first generation or second generation, doesn't matter. Clozapine works for both patients. It's thought to be probably the most effective antipsychotic in both categories on the market. And it's the only antipsychotic medication that approved by the FDA to reduce suicidal behavior in schizophrenic patients. Other ones are thought to reduce it, but they don't actually have that approval. Bottom line, it's really effective. It's reserved because it's got a nasty side effect profile and requires a lot of monitoring. That's all I want you to know about it. I'm going to talk about it a couple more slides just to highlight some of my points here. But Clozapine's a super specialty medication, as you guys can gather, and unless you go into psych and work with resistant cases, you probably will never see it. Okay, so clozapine's dark side causes tachycardia, drowsiness, drooling. So it's anticholinergic. So the interesting thing is why people drool a lot on clozapine. You'd think they'd get dry mouth, right? But they get, the idea is when you take it, you get this spike of anticholinergic effect that wears off, and then the opposite happens. So like people take clozapine at night because it's pretty sedating. They have dry mouth all night. They wake up and they drool everywhere throughout the day. So that's actually really common with clozapine. Weight gain is pretty bad too. It's similar to Olanzapine. Constipation, tardive dyskinesia, more common than other ones. Leukopenia, neutropenia, and agranulocytosis are our two ones we're really concerned about. That's really unique to clozapine. No other antipsychotics that I know of cause it to that appreciable of an amount. So you have to monitor people. This is kind of an example, and actually they don't care about white blood cells anymore. They've just gone to a neutrophil-only system that happened a couple years ago, so you can ignore that, but the labs are all the same. So when you initiate somebody, their ANC has to be above 2,000 or 2 or whatever your lab's reporting it as, whatever decimal point they're using. Then weekly for 6 months. So every week they're coming in and getting a blood draw. 6 to 12 months of therapy. If the results are good, then every 2 weeks. After a year of therapy, if all your results are perfect, you can go to every month, and that's it. You never get better than every month. It's kind of like INR checks with warfarin. Once a month is the max that you're allowed on this drug. If you discontinue therapy, you still want to follow weekly for 4 weeks, assuming that the ANC. If you discontinued because the ANC dropped below a certain point, you want to follow it until it gets back up, whether that takes 4 weeks or longer, whichever one kind of comes first. That makes sense. So what do you do if it drops? If you get mild leukopenia, so ANC 2,000 to 1,500, you do twice weekly until you're twice weekly monitoring. Keep clozapine going. You don't have to stop clozapine therapy. Moderate leukopenia, so ANC 1,500 to 1,000. Stop therapy. Check daily until you qualify for mild frequency. You can re-challenge, and if you do start clozapine again, you can you'd monitor weekly for a year automatically, regardless of how good your labs look. If your labs are perfect for 6 months, still supposed to monitor weekly for a year. Severe leukopenia, so ANC less than 100, you stop therapy and do not re-challenge. And agranulocytosis is less than 500, stop therapy, do not re-challenge. Follow using severe monitoring steps. So agranulocytosis is super rare on clozapine, but it does happen occasionally, and it can put your immune system in a really bad spot, obviously. So that's why we're really concerned about it. So this patient, kind of interesting, lab history, just to highlight this. CS was discharged, so she got approved for a trial of clozapine with weekly outpatient monitoring per the guidelines. In December 2008, she returned, and her ANC was 1,400. So that puts her in moderate leukopenia. They stopped therapy. This is how her white blood cells and ANC kind of trended. So this is where they dipped initially. So that's where they caught it. And you can see it went down further. So what they did at the time, actually, is because she had failed so many things, they actually kept her on clozapine. So you can, it's not like it's an absolute, you can't do this. It's not like, the cops are going to come arrest you as a prescriber and say, no, you can't do this. It's just you have to go through some red tape with the REMS program if you really want to do that. So what they did decide to do with her is prescribe her lithium. And I talked about lithium in the bipolar lecture. Lithium has an interesting side effect where it actually increases neutrophils. Basically, your body has resting stores of neutrophils, and lithium somehow releases them. That's all I know. It's called this neutrophil demargination process, and that's all I'm going to say. Anyway, so if you have true agranulocytosis or really severe cases, you wouldn't use lithium. But in this case, she had it occurring with her first 18 weeks of therapy, or a dyscrasia occurring with the first 18 weeks. But in her case, she was on it for a while. She looked really good. It just happened to be kind of a single-time blip in the radar. And she actually dipped a little bit further than that. So she got right at the 1,000 mark, which is really that severe cutoff threshold. And at that point, it's tricky as a prescriber to justify re-prescribing clozapine. But fortunately, she came back up after that with a recheck. She didn't quite hit that less than 1,000. Like the lab, I think, got her right at 1,000. And I think the VA was saying their labs round up, so she could have been like 998. She technically could have been below it, but we don't know. So for her, it was good. I got to interview her as a student, and I looked into her whole history while I was there. But she lived on her own when I talked to her. She had a case manager, but the case manager reports her like neat, orderly apartment, interacts well, has a boyfriend, denies depressive symptoms, seeks employment, designed to exercise more and lose weight. It's like normal things most people think about. Has some mild apprehensions towards daily activity, but doesn't really have any expressed paranoia. So the point in this is that sometimes drugs with really nasty side effects can be really helpful for people. And this person would probably be confined. I mean, if you think about some of these drugs not existing, what would this person do? Like confined to a group home, maybe, a best case scenario, a mental health ward of some kind. There's just not a lot of options for some people. And so sometimes our drugs, even though they aren't pleasant, are really effective for those particular patients. Anyway, that's just my summary. Let's take a quick break, and let's do 5 minutes, and we'll come back and talk about new agents. Then we'll do ADD really quickly after that. I was walking by a nurse's station, and departments do a huddle, and they have a 3 good things board, and somebody actually put a major spoiler under the 3 good things. I'm like, why would you put that in public where people can see it? And it's like, oh man, I'd freak out if I didn't know. Okay, anyway, starting up here. So newer agents, I just want to talk about some newer agents quickly. Some of these are getting actually quite popular. So some of the newer agents on the market are lurasidone, acetipine, and iloperidone. Brexpiprazole I mentioned already. Cariprazine is, I think, the newest one out there, or Vraylar is the name of that one. So the question is, can we get to that perfect antipsychotic, and do these new drugs get us any closer than we are already? So the perfect one, ideally, is going to decrease positive and negative symptoms. It's going to improve cognitive functioning and limit side effect profiles. So, and then, of course, be affordable by most people. Are we there? Are we not? So where do you really start with somebody? I don't think I really went through these anymore. I used to have some more slides on this, and I deleted them because I thought it was redundant. But let me just talk about these really quickly. Lurasidone is the only Category B antipsychotic, so they have some labeling in pregnant patients and pregnancy studies in animal models that appears better than some other things. Lurasidone is heavily pushed as an adjunct, kind of in the line of Abilify. Very effective antipsychotic. It's got a lot of uses. One of the things lurasidone has studied itself in heavily is cognitive benefit and being pro-cognitive. I don't know if it's really panned out for them, but they've had a lot of good animal model data and some smaller human trials that have shown that they have better cognition improvements compared to some other drugs. And really well tolerated, great side effect profile overall. Acetipine, don't really have much to say other than it causes QTC prolongation. It also comes in weird flavors like black cherry. It's a dissolving tablet, so people complain it tastes weird. I don't know. And then iloperidone is sedating and has some weight gain with it. So, and ultimately, other than Latuda having a few tricks up its sleeve, I think, potentially, depending on who you talk to, I don't think the rest of these drugs have a lot that I know of that make them like the next best thing. I think it's going to take some time to see them used, to get them studied more, and to get more long-term exposure with them to get more of a well-rounded picture. So anyway, okay, so how do you treat schizophrenia and where do you start? Anything but clozapine or olanzapine. Olanzapine could be an alternate if the patient doesn't respond well to a first-line clozapine. Of course, you have to try a few things first. Usually it's like 3 medications, and that kind of qualifies you for clozapine at that point. Insurance may dictate which agent you try. A lot of these are generic. Abilify went generic a couple of years ago, and that was really expensive. That one's generic. Lurasidone isn't generic yet, but I think that'll be the next of the newer agents to go generic. The rest of them, like brexpiprazole and cariprazine, those are brand new. Those will be a long time before they're generic. Iloperidone or Fanapt and acetipine or Saffras, those will be probably a little bit longer too, so see those off patent. So we're stuck kind of in the middle. We have some newer agents that are going off patent. We have some newer agents that are still on patent. Are they worth the cost? Again, if your patient's failed some other things and you think it's worth a shot, that's certainly up to you to try and prescribe it for them. I do see a lot of them used, so certainly they all get some game time. Combination and adjuncts for other conditions. A lot of these drugs, like the what am I trying to say? Bipolar. The bipolar lecture went over some of this, so talking about some of the drugs used for as adjuncts in other areas. Treatment resistant, we talked about clozapine. Non-compliant, long-acting IM products are nice for non-compliant. So that's really all I would think about. There's not a big algorithm with this. It's sort of choose your own adventure and see what works. There's not a lot of guidelines related to schizophrenia, fortunately. So for test purposes, I'd focus more on the side effect profiles of the agents. It's probably where I'll go with testing. Pregnancy, lactation, implication. I just put this on here. There's a lot of, okay, first of all, schizophrenic patients, usually if you have some kind of ongoing schizophrenia, it's recommended probably not to have children. Now that's an ethical thing, but that's generally an ethical recommendation. Just because somebody with ongoing schizophrenia who can't necessarily manage their own life probably shouldn't manage the life of a small child. So these would be more applicable to somebody on these medications as an adjunct, maybe for treatment-resistant depression, treatment-resistant bipolar. They're well controlled on them. What implications does that have? And certainly some schizophrenic patients may be really well controlled on a medication too. So I'm not trying to isolate a whole group of people, but generally speaking, that's kind of the recommendation. Yes?
What second sentence there? Some studies
that's probably birth defects. Sorry. Yes, that's just a trail off there. So the thing is that the people who have gone through pregnancies and have taken these medications, we don't study them in pregnant patients. But if they do retrospective analysis, kind of like with the anti-epileptic drugs, most studies found that the risk is actually quite low with the second generations and first generation agents. There are some that I think that was supposed to say just general birth defects, so slight increase, but for the most part, fairly safe. If you combine multiple psychoactive medications, that's where you see the higher risk rates go up. Quetiapine has the lowest rate of placenta passage, so if somebody's taking quetiapine for sleep, it's probably relatively safe in pregnancy. And then there's some other things here, but I'm not going to talk about them too much. Getting off topic a little bit. Okay, that's antipsychotics. Do you guys have any questions? All right.